Welcome back to another episode of the Red Cell series. So in this episode we shall discuss microcytic anemias. Remember, using our MCV classification of anemia, microcytic anemia are small cells with an MCV of less than 80, with the normal being between 80 and 100. Now, you may or may not be familiar with the mnemonic tails, which list the causes of microcytic anemia, and we shall discuss these individually and in detail during this episode. So these are thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning, and sideroblastic anemia. Now, a lot of you, like myself, may not like to just memorize mnemonics and list things, but rather understand the underlying pathogenesis to appreciate the pathology. So let me show you and describe a more logical way of understanding microcytic anemias by understanding what causes the microcytosis or small cells. So remember, red blood cells are formed by the process of erythropoiesis, where the erythroblasts, which are larger cells, divide multiple times to form erythrocytes, which are the normal red blood cells. So we know that the more the cells divide, the smaller they get. So a microcytic anemia can be thought of as the occurrence of an extra division. And the reason for this is that the red blood cell wants to pack its inside full of hemoglobin. So if there is less hemoglobin, the cell will divide again until it is satisfied that it is full of hemoglobin. However, the consequence of this is that the red blood cell shrinks in size. And this is why I have been emphasizing the composition of hemoglobin, because if one of these have decreased, then you get a decrease in hemoglobin, and thus you get a microcytic anemia. And remember, we said that hemoglobin is composed of heme plus globin, and the heme component is composed of iron and protoporphyrin. So using the tails mnemonic, let us derive the causes of microcytic anemia from this basic understanding of hemoglobin biochemistry. So let's start with heme. So again, this is composed of iron and protoporphyrin. So if we have a decrease in iron, we're going to have a decrease in hemoglobin. A decrease in iron is known as iron deficiency anemia. Now, we can have normal amounts of iron, but this iron cannot be used because it is locked up, secondary to the action of hepcidin. And we've spoken about this in part 4 of the Red Cell series in the iron physiology episode. So if the iron is locked up, we end up with a condition known as anemia of chronic disease. So now we have two causes of microcytic anemia. Now we can also have a decreased production of protoporphyrin, and this results in an anemia known as sideroblastic anemia. Finally, we have lead poisoning. Remember, in our hemoglobin synthesis video, we mentioned that heme is synthesized in the mitochondria, while lead can denature the mitochondrial enzymes, including enzymes involved in heme synthesis, such as ferrochelatase and ALA. So this also results in a decrease in heme production and thus a decrease in hemoglobin production. So that's the heme component done. Now there can also be a defect in the globin, and if there is a defect in the globin, this results in a condition known as thalassemia. With this basic understanding and with the mnemonic, you should be able to understand, recall, and consolidate the underlying pathology of microcytic anemia. If you can draw this very simple equation out, you should be able to recall the different types of microcytic anemia and from there derive the specific clinical features of these anemias. The two most common anemias in the world are first, iron deficiency anemia, and second, anemia of chronic disease. And these both have to do with iron, and we shall discuss these in this video. We shall discuss the other causes of microcytic anemia in the subsequent episodes. We'll start with iron deficiency anemia, as this is the most common anemia in the world and is defined as diminished red cell production due to low iron stores in the body. The most common cause of iron deficiency anemia in developed countries is gastrointestinal blood loss, whereas in developing countries it is a hookworm infection. Now, hopefully you still remember the iron physiology that we have discussed in part 4 of the Red Cell series. If not, please go back and have a listen, as this will make more sense to you if you understand the basic physiology of iron. Now, of course, there are other causes of iron deficiency anemia, and we can classify this based on 3 general causes, including reduced iron absorption, increased anabolic state, and increased iron loss. Pause the video here and take a shot at what conditions might cause each of these. These can either be physiological or pathological. Causes of reduced iron absorption include insufficient dietary intake. However, this is quite rare. Malabsorptive conditions include celiac disease. Remember, iron is absorbed in the duodenum, and celiac disease characteristically affects the duodenum. A gastrectomy can also cause iron deficiency anemia. Remember the role gastric acid plays in iron physiology. It maintains iron in its ferrous form. H. pylori and hookworm infections can also cause reduced iron absorption. Bowel resection, especially if it involves the duodenum, can also cause reduced iron absorption. Causes of an increased anabolic state include growth and pregnancy. Causes of increased iron loss include chronic gastrointestinal blood loss, which is the most common cause, menstruation, which is the most common cause of iron deficiency anemia in premenopausal women, as well as colorectal cancer, gastritis, and peptic ulcer disease. Now, in some resources, you might find that iron deficiency anemia can also be classified as normocytic normochromic. So that's NC, normocytic normochromic. And things might get a little confusing. To understand this, you need to understand the stages of iron deficiency, and this is very easy to understand. So when the body is losing iron for whatever reason, the first to deplete are the iron stores. So ferritin in the liver and in the reticuloendothelial macrophages begins to decline. Once these stores are exhausted, next to deplete is serum iron. So we end up with reduced serum iron as well as reduced transferrin saturation. We initially have a normocytic normochromic anemia, so NC, normocytic normochromic anemia. So the MCV and the MCH are both normal, so MCV and MCH normal. And the reason for this is that the bone marrow would rather produce normal red blood cells, even if less red blood cells are being made due to less iron. So the bone marrow would rather produce normal red blood cells that can function appropriately, rather than dividing the amount of iron available to produce smaller cells. So iron deficiency anemia starts off as normocytic normochromic anemia. However, once there is significant iron loss, the bone marrow is unable to keep producing these normal cells, so it produces smaller cells, which are microcytic. And then, as less hemoglobin is being produced, the cells become hypochromic, so this produces a microcytic hypochromic anemia. So both the MCV and MCH are low, so this is microcytic hypochromic. We've spoken about the general features of anemia, but let us touch on the specific features of iron deficiency anemia. These include atrophic glossitis, which is the absence of the filiform or the fungiform papillae of the dorsal tongue. So the tongue looks smaller and atrophic. Patients can also present with nail changes, including koilonychia, which is spoon nails. Patients can, albeit rarely, present with pica, which is a psychological disorder where the patient has a craving or an appetite for non-nutritive substances, and this is because the body is craving for iron. Patients can also develop Plummer-Vinson syndrome, which is an esophageal pathology with a triad of iron deficiency anemia, esophageal web, and dysphagia. patients with Plummer-Vinson syndrome have an increased risk of esophageal squamous cell carcinoma and may also present with glossitis. A differential diagnosis of microcytic hypochromic anemia includes any cause of microcytosis, and we've listed and explained these before. So how can you make a diagnosis of iron deficiency anemia? Pause the video and list what investigations you would do. So here we have a list of investigations we might consider doing. For each of these, pause the video and have a think at what each might show in iron deficiency anemia. So, hemoglobin would be low, and we have established that anemia is defined as low hemoglobin production. The MCV and MCH in the initial stages of iron deficiency anemia would be normal, and we have explained why this is. However, later they shall become low, so this causes a microcytic, which is the MCV, microcytic, and a hypochromic, which is the MCH, hypochromic anemia. And the reason for this, remember we said that the cells undergo an extra division because they are trying to concentrate their iron content. So as a result, we end up with smaller cells. The MCH would be low because we have less iron and thus less hemoglobin inside the cells. Serum ferritin will be low because if you recall from the stages of iron deficiency, the first stage is exhaustion of iron stores and ferritin is the stored iron, so ferritin shall decrease. Serum iron will also be low because remember stage 2 of iron deficiency is reduced serum iron. Transferrin is the plasma carrying protein for iron. Remember we mentioned that this is produced by the liver, so this would be increased in iron deficiency. The reason for this is that the body recognizes that there is less iron in storage, so it reacts by increasing hepatic transferrin synthesis to try and hunt for iron and replenish the iron stores. The total iron binding capacity, or the TIBC, is a measure of transferrin, so this will also increase. Again, the capacity of how much iron transferrin can bind is increased because less iron is bound to transferrin, and more transferrin is synthesized by the liver. Transferrin saturation would be low because less iron is bound to transferrin. The free erythrocyte protoporphyrin, or the FEP, would be increased. Because remember, hemoglobin, HB, is made of heme plus globin. The heme component is made up of iron and protoporphyrin. If the iron is low, there's going to be an accumulation of protoporphyrin, so this would increase the FEP. The red cell distribution index, or the RDW, would also be increased. Recall this is a measure of red cell size variation. Remember we said that initially the cells are normocytic and then they become microcytic, so there will be a spectrum of red cell size. If we were to look at these cells on blood film, so here we have an example, this would show various features that we have spoken about. So here we have a microcytic red blood cell, so this cell is smaller than, for example, this cell here. We also have hypochromic red blood cells, so paler cells, and we have a mixture of the two, hypochromic microcytic cells, as we can see here. We may also find pencil-shaped cells, for example this one here. From this slide, you can appreciate the variation in sizes and shapes of the red blood cells. So here there is anisocytosis, which remember is the variation in red cell size, and poikilocytosis, which is variation in red cell shape. Before we move on, let me touch on one rule of thumb that might help you when interpreting data. Whenever ferritin is low, the total iron binding capacity will increase. And you can think of this logically. If there is a decrease in ferritin, this means that there is a decrease in stored iron. So the body will recognize this and pump more transferrin to find and replenish the iron stores. So the total iron binding capacity, i.e. the total amounts of iron transferrin can bind to, will increase because first, there is less iron bound to transferrin, as there is less iron generally, and second, the liver is synthesizing more transferrin, so there will be more transferrin receptors available. And I hope that has made sense to you. If there is low transferrin, there is high TIBC. If there is high transferrin, there is low TIBC. Because if the iron stores are happy, then the body will recognize this and decrease the amount of iron it will hunt for. Once you have established that there is an iron deficiency anemia, you want to manage the patient to relieve their symptoms and hopefully cure them. The first step is to identify a cause, and a thorough history should elucidate this. Be sure to ask about the drug history, the dietary history, and the travel history. Make sure you are familiar with the local referral pathways, especially in these cohorts of patients, as there might be a more sinister underlying cause for the anemia, including cancer. If you have decided to replace iron, this is best achieved orally, and the best preparation for this is ferrous sulfate. Patients might be intolerant to this, so there are two alternatives listed here. You want to monitor the patient to make sure that their hemoglobin concentration is increasing, and treatment usually takes 6 months to replenish the iron stores. Now, the most common causes of failure to respond to oral iron include lack of compliance, continued hemorrhage or bleeding, or the patient might have an incorrect diagnosis. For example, they might have thalassemia instead of iron deficiency anemia. You can also give iron parenterally. There are specific indications for this, including intolerance to oral preparations and severe malabsorption. So now that we have dealt with iron deficiency anemia, let's take a look at anemia of chronic disease, another cause of microcytosis that results from an iron problem. The definition of anemia of chronic disease is within the name itself. So it is an anemia that occurs during a chronic disease. And importantly, it is an inflammatory mediated reduction in red cell production and survival. So it is principally caused by the chronic inflammation, and we shall discuss this shortly. So examples of chronic inflammation, or the etiology of anemia of chronic disease, is anything that causes chronic inflammation, including chronic infection, malignancies, rheumatological and autoimmune diseases, and post-operative patients. Anemia of chronic disease is also called anemia of inflammation because it can occur in either acute or chronic inflammatory diseases. Anemia of chronic disease is the second most common anemia in the world and is the most common cause of anemia in hospitalized patients. So what do all these causes of anemia of chronic disease have in common? And this is where we go into the pathogenesis or the pathophysiology to understand anemia of chronic disease. And once you understand this, it will become very simple for you to recall why anemia of chronic disease exists. So what these have in common is inflammation. Inflammation is key here. So inflammation is triggered by pro-inflammatory cytokines and results in production of more pro-inflammatory cytokines. One of these pro-inflammatory cytokines is IL-6, which induces the production of hepcidin. Remember, hepcidin is an iron regulatory peptide produced by the liver, which downregulates ferroportin, so it decreases the movement of iron from the enterocytes into the blood, and also importantly from storage sites, including the liver and the macrophages of the reticuloendothelial system, into the blood. So we have reduced red cell production due to the increase in hepcidin. So as we've mentioned here, increased hepcidin results in a decreased uptake of iron from the duodenal enterocytes into the blood, so less iron is being absorbed. It also locks up the iron in the storage sites, including the liver, spleen, and the macrophages of the reticuloendothelial system, and limits the movement of iron from the reticuloendothelial system to the erythroid precursors. Hepcidin also suppresses erythropoietin production. Remember, erythropoietin induces erythropoiesis, which is the production of red blood cells. So we end up with impaired bone marrow erythropoiesis, and this retarded erythropoiesis causes the anemia. So again, just to emphasize, the inflammation in the chronic diseases results in an increase of hepcidin, a downregulation of ferroportin locks up the iron in storage sites, so less iron is available for the production of red blood cells, so we end up with reduced red cell production and thus anemia of chronic disease. Elevated cytokine levels, including tumor necrosis factor alpha, have been shown to induce apoptosis in erythroid precursors in the bone marrow, so this also decreases red cell production, so decreased red cell production. So we have discussed why we have reduced red cell production. Let us explain why we have reduced red cell lifespan. So inflammation increases the activity of phagocytosis and free radical production. So that means that more red cells are phagocytosed and more red cells are damaged by the cytokine generated free radicals. So there you have it. We have reduced red cell production and reduced red cell lifespan. Now you're probably wondering, why on earth does inflammation cause the elevation in hepcidin to begin with? And it is good to understand this because you'll never forget the pathogenesis or the pathophysiology of anemia of chronic disease. So let us explain. When we encounter a bacterial infection, our body recognizes this and develops inflammation to get rid of the infection, even if we feel terrible for some period of time. Now, bacteria need the iron to grow, divide, and replicate, etc. And our body knows this, and this is probably something evolutionary. So, in response to the bacterial infection, we lock up the iron, starving the bacteria from iron, and we do this through the only way possible, and that is by increasing hepcidin. Now, unfortunately, we cannot turn hepcidin production off, so in chronic infections, we continue to produce hepcidin, and iron remains locked up, and we develop anemia of chronic disease. So for the following investigations, pause the video and write down what you think each of these might show. So the hemoglobin would be low. Again, we've established that anemia is defined by low hemoglobin. The MCV and MCH initially would be normal, so this causes a normocytic, normochromic anemia. And as the disease progresses, they can become microcytic, so low MCV, and hypochromic, so low MCH anemia. This is very similar to iron deficiency anemia. In the initial phase, the anemia is normocytic, normochromic, and this then becomes microcytic, hypochromic, as more of the iron available is used up. Serum ferritin would be high, and this is because, remember, in anemia of chronic disease, the iron is locked up, so iron will accumulate in storage, and this is represented by the increased serum ferritin. Serum iron is reduced. This is because the bone marrow cannot access the locked up iron, so it takes the iron from the serum to synthesize heme. So with time, serum iron would be low. The total iron binding capacity, remember we said that this is always opposite to serum ferritin. So in this case, serum ferritin is high, so the TIBC would be low. And this is because the body knows that there is a lot of iron locked up in storage, so it decreases its transferrin synthesis, so less iron is picked up. Transferrin saturation would be low, because remember serum iron is low, so transferrin saturation is low. As more serum iron is used for heme synthesis, this will decrease, and likewise serum transferrin saturation will decrease as less iron becomes available. The free erythrocyte protoporphyrin would be increased, and we have explained why. you could consider measuring the markers of inflammation, including the ESR and CRP, both of which will be increased in anemia of chronic disease. In terms of treatment, because the anemia is caused by a chronic disease, then treating the disease should treat the anemia. So treating the inflammation caused by the chronic disease will decrease the hepcidin, and in turn this will free up iron stores. Again, remember, iron is available in the body, but it is not accessible, so treating the underlying condition should treat the anemia. Now, in certain patients, you could use exogenous EPO, erythropoietin. Remember, hepcidin also decreases erythropoietin production, so giving exogenous erythropoietin may relieve some of the symptoms of the anemia in certain patients, including patients with cancer and renal disease. And in some patients, you might consider giving supplementary iron. Finally, I just wanted to mention that many patients with anemia of chronic disease also have a true iron deficiency anemia, so the two can coexist. Please like, subscribe, and share our content with your friends and on social media pages. Our mission is to develop need-to-know video content and question banks that remain free for your use. We are unable to keep doing this without your support. Thank you.